All attendees are in listen-only mode.
All right, everyone, welcome back. It's Mike and Bettina here. We are so excited that you made it live with us tonight. We have a great webinar lined up, and we're going to make sure Dr. Jill and her screen are working okay. So just give us a quick second. Looks good so far on my end. So we are live with Dr. Jill Carnahan. She has her undergraduate degree in bioengineering from University of Illinois at Champaign-Urbana. She attended medical school at Loyola University Stritch School of Medicine in Chicago and completed her family medicine residency at the University of Illinois program in family medicine. She's board certified also in integrative medicine as well. She's a functional medicine expert, practices in Boulder, Colorado, does a lot of teaching for A4M and IFM and so forth. So Dr. Jill, thank you so much for being live with us tonight.
Thank you, Mike, and I love teaching, so I'm really excited to be here. And to our listeners, I am so excited to have you all join us, and hopefully you'll get some good information and some really practical tips tonight. I always find when I go to lectures that it is so important not just to get the background of the pathophysiology and biochemistry, but to get the practical tips that you can take tomorrow to your office setting and have some insight into what to actually do to treat the patients and get them feeling better. So that's what I'd like to offer you tonight. I know your time is precious, so I've got a lot of slides, but I'm going to do my best to be done on time and leave a little bit of room for questions as well. So I'll be watching my time, and if I see that we're running low, I may flip through a few slides quicker. So look forward to talking to you tonight. This is me, and just to briefly, I'll show this at the end too, but you feel free to contact me, website, I have a blog, there's a free newsletter, all kinds of things. This is all just because I enjoy teaching, and again, if you want to connect with me, make a note and hook up. There's also a LinkedIn group where I post lots of articles and things. Okay, so a couple disclaimers to start us off. I'm going to let you read these.
Perfect.
Okay, 5R program. If you've been anywhere near functional medicine, you're familiar with this, but I can't start a gut health program out without starting with the 5R program. Basically, the principles of the 5R program are what we use to find the underlying cause of illness in gut issues and then to find balance and restore health to the patient. Basically, it consists of 5 parts: remove, replace, reinoculate, repair, and rebalance. And I'm going to talk briefly about each of these before we go into specific microbial infections. So the first one is remove, and I put stress up there first because sometimes we think about abnormal microbes, which our whole talk tonight is going to be about, but you don't want to forget that stress component, which makes such a big deal. And as we know, the gut and the brain are so intricately connected. And because of that, if a patient is under stress and you're trying to give them antimicrobials and give them probiotics and treat that gut, if they're still having an incredibly high stress lifestyle, working 80 hours a week, getting by on 5 to 6 hours of sleep per night, you're never going to heal their gut. So you've got to ask the questions and make sure you address that. Remove also includes food sensitivities. So elimination diet is a really important piece of the puzzle. And a lot of times that's the first tool I'll pull out of my toolbox to figure out if the patient has sensitivities or determine if the foods are causing problems as well. And of course, you can use drugs or herbs to eradicate. And sometimes people don't think about genetically modified foods, xenobiotics, harmful things that the containers we eat our food out of, how we fix and prepare our foods with aluminum foils and plastics and things. But these are really key. And I just want to mention briefly about genetically modified foods. There's increasing glyphosate exposure because of the chemicals that are used not only on genetically modified foods, but even when they're getting ready to harvest the wheat, which is not a genetically modified crop, they spray glyphosate all over that conventional wheat. So we're getting doses of this in astronomical amounts, and we know that it has a profound effect on the gut microflora. So the first thing you want to do is get your patients off genetically modified food. And right now, the really only way you can do that is get them on an organic diet. Replace is adding back those things that the patient doesn't have to break down food. This could include plants or fungal-based enzymes, pancreatin or prescription enzymes, which would be indicated if the patient had a pancreatic insufficiency. We could also include hydrochloric acid, and I'm going to spend a little bit of time tonight talking specifically about hypochlorhydria, which is a condition that is from low stomach acid, and the tips that you might find to diagnose that. Bile acids are essential as well. And there's botanical things that you can use to aid digestion as well. So in the cases that aren't as severe, a lot of times you can start with Swedish bitters, ginger, bromelain, or papain, or more simple interventions. The next R is for re-inoculate. And interestingly, we used to think that probiotics were like seeds in a garden, that you would plant them and that the gut flora would grow and flourish. And we know that's not the case. We know from research studies that after about 2 weeks of discontinuing a probiotic, those levels will go back to the previous state. So these guys don't always take up residence. And the amount of research that's coming out currently about different strains and types of probiotics is amazing. And I can't wait to see in the next 5 or 10 years, because I think we're going to be using probiotics to modulate the immune system and modulate the gut, very specific doses and strains and species. I think right now we're just at the very beginning of this, so we don't have all the data to use those very specific strains and species in all cases. Things like prebiotics, which feed the probiotics, are important, but you have to be cautious in some cases like SIBO, bacterial overgrowth, or yeast infections, because those prebiotics can feed the bad guys as well. Fiber is important, and then you can also use Saccharomyces boulardii in certain cases. Repair, as you can see, the list is long, and I won't go through it all, but there's lots of really important things, because as you get rid of this abnormal microbial population, you need to make sure you're healing that mucosal lining that's been damaged. And so these are all items and things that you can use to induce healing. Rebalance. This kind of goes back to my comment on stress. You've got to have this patient in balance. You've got to have them in a good lifestyle, into a place where they can actually rest and relax and restore. We know that when we are under stress, our sympathetic system is activated, and that shuts down the gut. So if we are constantly in a fight or flight, again, we're working those 80, 90-hour weeks, not getting sleep, rushing from thing to thing, we're eating at our desk or standing up or in the car, there's no humanly way possible for that food to break down and digest appropriately, and we are going to have some gut imbalances. Adequate sleep, mindful eating, and then balanced brain and nervous system is really essential. If you've never heard of heart rate variability, I don't have time to talk about it tonight. I think Mike's had a couple guest lectures who have, but it's a really profound way to impact the health. And I encourage you to check out Heart Math. There's even some iPhone apps now out there. And of course, you can include acupuncture, yoga, tai chi. And for me, I like to do prayer and meditation. This was a wonderful quote, basically talking about the mindfulness, just being aware of what's happening right now without wishing it were different, enjoying the pleasant without holding on to it when it changes, and being with the unpleasant without fearing it will always be that way. So I like that for a reminder. Basic stuff that you need to have on board for a healthy gut. I frequently recommend a protein smoothie, and you need a clean hypoallergic protein powder, which Zymogen offers multiple choices to choose from there. L-glutamine is the primary fuel for the cells that line the gut, or the enterocytes, and this can also heal mucosal damage. So as far as the repair of the 5 R's, this is one of the key fuels. Vitamins A and D are critical and synergistic in healing the gut, and if someone is having malabsorption, they're not absorbing fat-soluble vitamins, you need to check these levels and replace them, and usually it's about a 4-to-1 ratio. There's some different schools of thought on that. You do have to be careful about too much vitamin A, but initially if someone has had malabsorption, you can do pretty significant doses in the first several months. Probiotics, essential fatty acids, B vitamins I put on here because I have been studying methylation like crazy. Again, I know Mike has an interest in that area as well, and this is so critical. And to have those B vitamins to help with maintenance of energy, mitochondrial function, and methylation processes is really essential. What I'm beginning to find is those tough cases that don't get better, when I start to address the methylation imbalances and some of the predispositions they have genetically, sometimes that's the piece that turns the corner. And then a high-potency multivitamin. And honestly, that's kind of an insurance policy. I don't always start off with that. So sometimes I'm treating specific insufficiencies before I get them back on a multivitamin. So until their gut can handle it, that's usually the last step. So this is just for a cute little laugh. I happen to have two puppies that I love, and this is just a great comic. Okay, so we are going to dive right into the case studies. And like I said, I always find these so practical because as I'm talking, I hope that you'll be imagining a patient or a friend or family member and someone that you can apply this knowledge to. They certainly don't represent all cases, but hopefully it will give you some insight. Our first case is a 62-year-old male. He comes in for dyspepsia, foul gas and bloating, and frequent belching after meals. So it's more the upper GI symptoms that he's having trouble with. He's an avid runner, but his gut symptoms always affect his ability to run, especially over the last several years. He literally will be going out to do a 13-mile run, and he'll have to make sure he knows places along the way that he can use a restroom because he'll have bowel disturbances along the way and have that acute urgency. He does have a congenital abnormal kidney, IBS diagnosis from his primary doc, sinusitis, gout, and a history of Raynaud's syndrome. These are his meds and allergic to sulfa. So his testing shows, we're going to jump right to the punch, positive H. pylori. So what is H. pylori? Well, H. pylori causes gastric mucosal damage. It lives in the stomach, and it tends to be a very hardy bacteria that's one of the few that can survive in this acidic environment. So it's a very difficult to eradicate bug, and we know it can do some pretty profound damage. There's an association with H. pylori and gastritis, gastric ulcers, and even gastric cancer. Now, the question in more recent years is this a normal bacteria in some people, and do we always need to eradicate? I don't know that we have a firm answer on that, but I will tell you when I have someone that is symptomatic and I test positive for H. pylori, I usually go ahead and treat them. So that's my criteria. Again, that doesn't indicate the standard, but it is I feel like a good way to go. Okay, so H. pylori, how do we test for it? There is urea breath testing available. It's expensive and you have to have someone who is doing it. Serology, you can test to see if the patient has ever been infected with H. pylori by doing blood work. The problem is if they have eradicated that infection, they can have ongoing IgG elevations, and because of that, you don't know if they have a current or past infection. If you do see an elevated IgM, of course, that means that it is an active recent infection, and then you would treat. I tend to use the stool antigen. It's about 90% sensitive and specific before and after treatment. You don't want to repeat the test prior to about 4 weeks being after the antibiotic or antimicrobials. So that's an important point, but I do always test after treatment to make sure that I have cured them. The importance of that is H. pylori can be very hard to eradicate, and because it's hard to eradicate, you want to make sure that you got it. It's not uncommon to have to do 1 or 2 or even 3 courses. I usually ask the patient, I find herbal regimens can be effective, probably not quite as effective as antibiotic regimens, but sometimes I will start with the herbal regimen, and if that doesn't work, we'll move on to an antibiotic regimen. This is just a diagram from the research on the standard of care for treating H. pylori and the diagnostic algorithm. So it's the most common bacterial infection in the world. I was actually surprised when I did the research and found that point. About 30 to 40% of the U.S. population has this bacteria. Like I said, it has a specific affinity for the stomach mucosa, and it tends to disrupt permeability. So as we talk about permeability, leaky gut, and some of those things, we know that this can be a player. Now, the big thing is it definitely creates inflammation, and it can be a predisposing factor to gastric cancer. Now, the big thing that I find, I deal with a lot of autoimmune disease as a functional medicine expert, and because of that, you see a definite correlation in the research with systemic autoimmune disease and H. pylori. I'm going to give you a few examples. So prolonged interaction in this research study showed that H. pylori was definitely a plausible infectious agent for triggering autoimmunity. And as you may or may not know with functional medicine, we are always looking for triggers or things that basically took a person from a predisposition to disease into the active disease. And H. pylori is one of those triggers. So if we see it, again, especially in someone with an autoimmune disease, you absolutely want to eradicate this bug. These are some of the treatments specifically. Treatment involves taking multiple medications for 7 to 14 days. Now, again, I like to do herbal regimens when possible, but I do find they are not as successful. So these are the 3 different options: triple therapy, quad therapy, and sequential therapy. And I haven't found one to be necessarily superior in my clinical practice. I tend to go with a sequential therapy because the patient doesn't have more than one antibiotic at the same time, and they tend to feel better on that regimen. Other treatments naturally include mastic gum, zinc carnosine, berberine, and bismuth. And sometimes I'll use more than one or all 4 at the same time. And then you want to include some treatments for mucosal healing, because most of the patients who have this are very symptomatic with symptoms of gastritis or heartburn or stomach pain. Deglycerized licorice is a wonderful thing for heartburn and stomach pain. It tends to line the gastric lining, the mucosa, and give some very immediate relief. And those come in capsules or chewable or in combination formulas. L-glutamine powder, another great one. Aloe and marshmallow root. And aloe, you do have to be cautious if the patient has diarrhea or loose stools, because that can induce loosening of the stools. Marshmallow root you can literally buy. In Boulder, we have a little herbal pharmacy where you can buy raw marshmallow root and make your own infusion. A pretty simple thing to do. This study showed mastic gum had a very high bactericidal, meaning killing the bacteria, effect in vivo. So some natural agents have some pretty profound effects. Zinc carnosine, one of my favorites, also showed a reduction and improvement in H. pylori. So I wanted to show this slide because there's a definite connection in the literature. I'm going to flip ahead and just show you these. There is, I'm sorry, we're going to go back about 4 slides away here. I'm going to have all the resources and you'll get a copy of that, but I have links to studies for each one of these connections if you want to look at the research. But there's connections with H. pylori and ischemic heart disease, in ITP or troubles with platelets, iron deficiency anemia, autoimmune thyroid disease, lymphoma, and atrophic gastritis. So lots and lots of connections. The last one there is when you see an autoimmune case of hypochlorhydria, and that's very commonly coexistent with H. pylori. So you want to make sure you check stomach acid levels and treat, if appropriate, in a patient who's had H. pylori. There's something called molecular mimicry, which again you may or may not have heard of. Basically, if the body is exposed to a bacteria, the immune system wants to fight that off, and naturally it creates antibodies to that bacteria. It could be food or it could be a bug, and the body creates these antibodies, and then those antibodies get confused, and instead of attacking that bacteria, they can cross-react with things like joints or brain or gut tissue and create autoimmune diseases. So this is a pretty important piece of the puzzle when you have a bacterial trigger that's causing autoimmune disease, and it can result in things like thyroiditis, colitis, multiple sclerosis, and joint pain. Interesting little fact, celiac patients have a 10 times rate of other autoimmune disease and thyroid disease. Okay, so this is just an article. If you want to look up, I have links at the bottom, and those all link to these complete articles on infections and autoimmune disease. There's a definite connection. This is obviously quite detailed. I love this kind of stuff. You may or may not, but the basic point here is that these are some ways that the body does molecular mimicry, where it gets confused and creates these antibodies that cross-react to self, and then that leads to an autoimmune disease or inflammatory processes that create destruction and damage and inflammation. These are other bacteria that are not H. pylori but have been associated in the literature with infections and autoimmune disease. So Klebsiella has an association with spondyloarthritis, Yersinia with autoimmune thyroid disease, Campylobacter with reactive arthritis, and Salmonella the same. And even more, we have E. coli associated with uremic syndrome, Candida associated with Crohn's disease, Strep pyogenes with rheumatic fever, Mycoplasma and Chlamydia with multiple sclerosis. And then there's others with rheumatoid arthritis. Okay, this is just to remind me, commercial break between our next case. So I love this. Laughter's the best medicine, but your insurance only covers chuckles, snickers, and giggles. All right, case 2. 27-year-old female presents with fatigue, severe bloating after meals, frequent diarrhea, and eczema. So how many of you already know that eczema and skin acne, things like that, are often connected with an abnormal gut microbe population? Very first thing I look at when someone comes in with rashes, eczema, autoimmune skin disease, persistent acne, I always go to the gut because the gut and skin are so connected. And again, I couldn't see your virtual hands raised, but most of you probably knew there was a connection. This patient happened to have a childhood multiple ear infections, and that just means to me there's been multiple antibiotics, which we know antibiotics do damage to the gut microbe population, sometimes permanently. She has many environmental allergies, and she was diagnosed a couple years ago with Hashimoto's. She did, before coming to see me, go on the autoimmune paleo diet, lost 40 pounds. And when we did testing, this is what I saw. Now, this is a snapshot of organic acid testing. I use this very frequently because it gives me another glimpse of another part of the gut. So stool testing is a wonderful tool as well. I use that very frequently, but sometimes I want to look at the small bowel or other parts of the gut that aren't shown in the stool test, and this can show me the entire population in the body and if there's a problem with bacterial markers. These are urinary markers that tend to be high if there's bacterial overgrowth or yeast overgrowth in the gut. And as you can very well tell with this person, she has all of her bacterial markers in the red and 2 of her 3 yeast or fungal markers in the red. So there's definitely a problem with bacterial and fungal dysbiosis. And this is an article about SIBO, which is small intestinal bacterial overgrowth, and some of the differential diagnosis of gas and bloating and distension. So this is all the different things you might want to be thinking about when someone presents. And as you can see, right around here, hopefully you can see my pointer, we've got small intestinal bacterial overgrowth. This is definitely on my radar because there's an epidemic of small intestinal bacterial overgrowth, and it can be very tricky to diagnose, and it can be a little bit even more tricky to eradicate. So SIBO. So what is SIBO? SIBO is we should have large 10 to the 11th, 10 to the 10th populations of microbes in the colon. That's where they're supposed to reside. But for multiple reasons, sometimes that bacteria either migrates up through the ileocecal valve into the small bowel, or if there is lack of stomach acid or something else going on in the upper stomach, it becomes present in the duodenum or early in the small bowel. Our small bowel is not meant to hold a large population of bacteria. So what happens with this is it starts to create inflammation, it creates damage to the lining, it creates things like permeability, leaky gut, it creates malabsorption. One of the clues I see that makes me look for SIBO in a patient is if they have a chronically low B12, if they have anemia with no other explanation, if they have low fat-soluble vitamins, and if they have a low ferritin. So if I see markers of malabsorption, I'm going to first look and make sure they don't have SIBO or SIBO. Brain fog is super common. You know those patients who say, I could just fall asleep after I ate lunch. Not only lunch, but any meal when they feel really foggy and especially tired right after eating. This is really common because all that food goes into the small bowel and ferments and creates toxins, and then their brain doesn't work right and they want to lay down and take a nap. Okay, conditions associated with SIBO. So these are some of the things you may see in association and that are connected. I'm not going to read these all out for you, but as you can see, there's a lot of things that are associated with it. I will tell you some clinical pearls. If you have someone who enjoys their alcohol a lot, someone who maybe previously was an alcoholic and recovering, there's a direct connection with SIBO and alcohol. So you want to check them and make sure that's not a problem. Patients with rosacea, there's multiple studies showing rosacea may be linked to SIBO. Same with fibromyalgia, chronic fatigue syndrome. So things like advancing age cause lower stomach acid. So as we age, we're more likely to have this. And people with immune deficiencies, so low SIGA or low stomach acid. Okay, here's the study for rosacea. So I mentioned that, and this is the actual study that showed they had a significantly higher prevalence of SIBO over the controls, and that eradication would often include cause complete remission. So once again, I told you when I look at the skin or talk about the skin of someone's face or other body parts, if they have problems or complaints on their skin, I always look at the gut first and treat that. It's amazing the skin will be so clear when you treat the gut. How do you diagnose SIBO? Well, as I showed you at the first slide after the case study, I do organic acid testing for nearly every patient, and that gives me clues. The gold standard is a breath test for hydrogen and methane, and if I have any question, I will often order that test for them as well. This is really important. I didn't know this in the very early years of my clinical practice, but a stool test is not diagnostic for SIBO. So you really cannot determine if someone has SIBO or not from a stool test. Now, I will tell you, after seeing hundreds and hundreds and hundreds of stool tests, I can start to see patterns that may indicate there's a problem. Again, it's not diagnostic, but you do start to see patterns that could indicate. Diet intervention for SIBO. So FODMAPs you may have heard of, and this is a list of the things that are fermentable that are not allowed on a FODMAP diet. And this shows you in a little bit easier form. These are foods that are suitable on a low FODMAP diet. And again, what we're looking at is fermentability, because these bacteria like to ferment certain foods. And these guys are the foods that they like to ferment. So these would be the foods that you'd ask that patient to avoid. I consider the FODMAPs kind of the entryway into diet changes for SIBO, and if that doesn't work, I'll often move on to a modified paleo diet, maybe a SCD diet. In extreme cases, elemental diets can be helpful. I do not use those too often, but again, in the cases that are very resistant to treatment, it can be a lifesaver. Medications include xifaxan, metronidazole or tinidazole, and then prokinetic agents if needed. You always want to, when you're treating SIBO, find the underlying reason why they got it. It could be things like slow bowel motility. It could be things like bowel resections or gastric surgeries like gastric bypass. Any of those things can be predisposing. Low stomach acid is another one that you might find, and when that happens, you need to replace that stomach acid or they will keep getting back the SIBO once you treat it. So again, you've got to always look for upstream factors that are causing them to develop this disease, because if you just treat with a medication or an herb, you will get this coming back over and over again. So you've got to go and treat the underlying root cause, which is the core of functional medicine. I will tell you there is a predominant form of SIBO that tends to present with diarrhea, and that's often associated with the hydrogen forms of bacteria that tends to respond better to xifaxan. And there's a methane predominant producing bacteria, and those tend to present with a little bit more constipation. Sometimes they respond to xifaxan, but when they don't, that's one of the times I know to add either flagyl or metronidazole or tinidazole to the regimen. There's some great herbal treatments, and what I have found in the literature and in my own experience is that these tend to work better when you're doing a high dose of berberine, oregano, and garlic are my three favorites, but you can use some of these other ones as well. I will also say this is really important. Probiotics may or may not be useful in SIBO. Sometimes patients actually have an elevated percentage of lactobacillus in their small bowel. And when that occurs, they actually respond very poorly to probiotics. And if that's the case, you certainly don't want to give them lactobacillus as a probiotic until you've cleared out the SIBO. Here is a study on rifaximin, my favorite drug for SIBO, and the effectiveness of that. I mentioned several times hypochlorhydria, and this is so important because if you treat SIBO without treating the underlying cause, if it's hypochlorhydria, you will not be doing that patient a service at all. There's several ways you can do empiric testing by giving them betaine HCl with meals. You can do Heidelberg is the gold standard and usually done through a gastroenterologist. I also look at serum zinc, serum ferritin, B12, methylmalonic acid in the serum, and gluten sensitivity because these can all be markers of hypochlorhydria. This is another one. Hopefully you're still doing physical exams. If you see the patient's nails have white spots all over them, that's often an indication of brittle or breaking nails or hair. You need that protein to make the nails and the hair, and if you're having problems with assimilation of proteins due to low stomach acid, you'll often see or hear their complaints of breaking hair or breaking nails or these white spots. Common symptoms with low stomach acid would be bloating, belching after meals, burping, sometimes hiccuping. I told you the weak and peeling cracked fingernails, skin lesions, low iron, B12, chronic intestinal infections. Our stomach acid is our first line of defense against invasion from microbes. So if they're having chronic problems with infections, you may want to check stomach acid. Things like vegetarian lifestyle. Now, this is an interesting one, and I can speak from both sides because I was a vegetarian for 14 years. And then I realized for me personally with my genetics, it was very detrimental because I had gravitated towards that because I didn't know it, but I had low stomach acid and meat never made me feel well. I always did not like the way I felt. It felt heavy. I didn't digest it well. I was tired. And I just thought, oh, I'll give up meat. And I did for 14 years. But once I replaced stomach acid, that all changed. And now I'm more of a modified paleo lifestyle. And for me, it works very well. And so if you do have a vegetarian, I start to ask, is it because ethical reasons or is it because you don't feel well after you eat meat? And if it's because they don't feel well after eating meat, you want to check into if they have low stomach acid because I have found over and over again with testing, this tends to be one of those things that causes people to go towards that diet because they feel better. Treatment is betaine HCl with or without pepsin. And here's the instructions. Okay, another commercial break. This is the pharmacy. Take one daily with a tomato and cucumber. Wouldn't that be wonderful if this was our true pharmacies where they were treating with food instead of drugs? So I love this cartoon. Case number 3. Okay, so this is a 31-year-old female diagnosed with lupus. So we've got autoimmune disease, chronic constipation, reflux, and abdominal pain. She had been taking prednisone and methotrexate for her lupus and complains of recently weight loss. She also complains of migraine headaches, insomnia, depression, and anxiety, and she has that constipation we mentioned before. Excuse me. This is her diet and some of the past medical history. As you can see, there's lots of other things going on. I won't read this to you. So her test, again, jump to the chase. This is positive candida on the stool. So she has a yeast overgrowth in the gut. And this is a sensitivity from the testing. So what this tells me is the agents that I can use to treat the yeast. This doesn't always come back with the stool test if they're unable to culture it and grow it for SNS, but when they do, it's very helpful. And as you can see, I put this on here because these are the pharmaceutical agents that are available for treatment at the top, and then there's multiple botanicals. I tend to use a caprylic acid, undulaceic acid, olive leaf, berberine, in combinations of all of those, but any of these on this list work well for yeast, and again, it depends on the patient's specific situation. So risk factors for candida would be broad spectrum antibiotics, diabetes, which increases blood sugar, and of course yeast thrive in a sugar environment, so diet has a big effect as well. In fact, I would venture to say our standard American diet is so high in processed foods and sugars that there's a lot of people walking around with the yeast overgrowth and they have no idea. Pregnancy or hormone replacement can increase risk of candida as well. Extremes of age, high stress, as we've seen. Diagnosis, you can do a stool profile. That's usually what I start with. As you saw in one of the earlier slides, you can do organic urinary amino acids, and if these are elevated, they indicate there may be a problem. And then you can also test immunoglobulins in the immune system in the blood work. And I will frequently check all three of these because, again, I find different views of the same problem, and if I see indicators of a problem on all three of these tests, well, I certainly will treat that patient. Common symptoms. So doesn't this sound like a ton of our patients? Fatigue, poor memory. I find candida and yeast especially cause trouble with brain fog and that poor memory, spacey feeling. And they can have anxiety, mood swings because of the hormone connection with yeast. A lot of times prior to their cycles, they'll feel a lot worse, or they'll have really bad PMS symptoms, joint pain, muscle aches, rashes, vaginitis, and the history we talked about. So what do? Well, just like the SIBO, you've got to address diet, and you have to start with diet. The Candida, or quote, Candida diet is pretty difficult, but people feel better. Now, Candida, more than most of the other organisms, when you start on a change, a lot of times people will feel worse before they feel better. That's called a Herxheimer or die-off reaction. And part of that is the body's ability to detox these dying organisms. So I always say you don't want to push the patient too hard. You want to make sure you're supporting their detox mechanisms, and they should tolerate pretty well if you're doing that. And the goal is, if they're having trouble with symptoms, you back up on treatment until they get to a stage where their detox has balanced out. I always have a word picture for patients. It's kind of like there's these huge green waste management trucks that come by and take out our garbage around here. And if you have one of those big trucks taking out your garbage, it's no problem. But if you've got a little, 12-year-old boy on a bicycle, and that's your garbage relief system, and some of these patients with poor detox, that's what they've got, you've got this huge burden of garbage, and that little bicycle is not going to be able to take out all the garbage. So you got to kind of think about that when you're treating these patients and not rush them too quickly in the treatment. These are, as you've been able to read, some of the keys with the diet changes. I do ask them to avoid fermented foods, including alcohol, moldy foods, yeast, and most people I will have be on a low sugar, low carb diet. Treatments you saw before: fluconazole, itraconazole, nystatin. Occasionally I will use compounded oral amphotericin B. It can be profoundly effective in resistant cases, and orally the toxicity is almost zero compared to the IV form, which is the typical pharmaceutical with its risk for nephrotoxicity. Herbs and herbal combinations include the ones listed, and they can all be very effective. And often I will rotate these if one is used for the first 4 weeks or so, and then switch off, or use combinations. There's some wonderful combinations, which we'll talk about at the end of the seminar, for treatment of Candida. Constipation, which was this patient's presenting symptom. I'm not going to go over all these, but this is a pretty important tool in your toolbox to have. I suggest you jot these down, or you'll get a copy of the slides afterwards, because these are some really helpful things for patients with chronic constipation. And then I mentioned Herxheimer or die-off reactions, and to treat those, you just want to aid that patient in detoxifying. So first thing, you might want to reduce the dose or frequency of what you're giving them. You may want to add enzymes, increase hydration, and I found that mineral water, or even San Pellegrino, Perrier, some of those can be profoundly beneficial because of the mineral alkalizing content. Adequate sleep is essential. Activated charcoal may help. And again, more list of things. Another one, the second to last, is another favorite: Epsom salt baths. Patients love them, and these can be profoundly effective because you're getting the magnesium and sulfate you need to enhance detoxification. And above all, you don't want that patient that you're treating to get constipated, because they're going to reabsorb those toxins even worse. And again, that's why I started off with treatments for constipation, because you tell them, if you start getting constipated, increase your magnesium, increase your water, increase your ascorbic acid, whatever you need to do. And if you're still having trouble, give me a call, because we don't want you to be constipated. Okay, I loved this article by NPR, and I had to include it because I thought, how cool that NPR is talking about the auto brewery syndrome. And their subtitle, apparently you can make beer in your gut. So fermentation in the gut is a real problem, and this happens with either SIBO or Candida, where our gut microbes actually ferment the food we eat and create gas, bloating, pain, inflammation, permeability issue. And this is one of the reasons why some people have such trouble with fermented foods. Fermented foods are loaded with natural probiotics, but as you probably noted if you've been in clinical practice very long, there are certain people who do not do well on fermented foods, and this is why. So when they sit in that small intestine and ferment the foods that we eat, this creates great gas and bloating. And some of that fermentation byproducts, for example, with yeast, can be acetaldehyde. This is toxic. This is the same molecule that's detoxified in our liver when we drink alcohol and creates the hangover feeling. So as you can remember when I talked about Candida, common symptoms are brain fog, headaches, fatigue, and that's the same types of feelings you might have with a hangover. So there's a connection. You also might find this person has a craving for alcohol, and when they drink alcohol, they feel temporarily better. That's all part of that yeast syndrome, because that keeping that level of acetaldehyde stable in the blood can be, again, make the patient temporarily feel better, even though it's doing them harm long term. Okay, I want to briefly talk about histamine intolerance. I especially want to talk about this because Mike has a phenomenal product for histamine issues, and we'll talk about that. It's called Hist-DAO at the end. So people with histamine problems can really use this to decrease histamine. So this is a complicated diagram, but again, I love this kind of thing. I will not go through all of it, so I apologize for those of you that are engineers out there. Excess histamine may occur with inflammatory bowel disease, celiac, dysbiosis, and there are people, if you look at the right side of the column here, genetic polymorphism. So people with methylation issues have trouble breaking down histamine, and often you'll find these are some of your toughest patients. So they can have trouble with histamine and the symptoms that histamine produces. And if you glance back at this, and we look at this column right here, excess histamine will present as itching, skin redness, flushing, red spots, rashes, hives, sometimes diarrhea, nausea, dizziness. So all of these things you've seen in different patients and may or may not be related to histamine, but it can be related to histamine, and histamine can be produced by certain microbes in the gut. So tips for naturally lowering histamine would be vitamin C. It's a natural antihistamine. Some of these patients will do 5,000-6,000 milligrams a day to be on that antihistamine. B6 can be helpful. Quercetin is one of my favorites. I use that very frequently, and a very powerful natural antihistamine. And of course, there's lots of medications that you can use, and you can use an enzyme with meals like Hist-DAO. Some patients are significantly affected enough that you have to put them on a low histamine diet. Hopefully this is temporary and not permanent, but again, if there's genetic reasons where a patient has trouble breaking down histamine, sometimes adding or taking out these foods, which is a lot of good stuff, can really help them. So these are your higher histamine foods. Things that are fermented, again, can be a problem for these histamine patients that have trouble breaking it down. And again, if you look at this list and people are complaining of not feeling well after these foods, that may be their root cause, is an excess histamine. Histamine is a known permeability problem. It creates intestinal permeability. If you think about when you get allergic reaction, your membranes in your sinuses swell up, and all of a sudden you get stuffy and congested and sneezy, and you feel like you can't breathe. Well, that reaction is basically increased permeability from the mast cells releasing histamine. And that same thing, if it happens in the gut lining from either food sensitivities or microbes that are producing histamine, whatever that histamine is coming from, it will create permeability in the gut. So this is a vicious cycle, because if you aren't taking care of the microbes and the imbalances that are creating excess histamine, that patient is going to have a problem with permeability or leaky gut. They're going to develop food allergies, and it's a vicious cycle that you've got to stop. And this, again, there's multiple. I just pulled 2 articles here, but there's so many articles out there on the effect of histamine and inflammatory bowel, irritable bowel, children with chronic abdominal pain, and there's a connection here. Okay, moving right along, case 4. See how we're doing on time. I'm going to speed up just a little bit. Okay, 26-year-old female with ongoing pain, a 6-month-old baby, and just exhausted. She had her gallbladder removed, but she's still having problems. Lost 10 pounds. She did travel to Mexico last year. That may be a clinical clue to what's going on. This is some of her past medical history. She has blastocystis hominis. This is a parasite. It's a small cellular organism. It's actually quite common, and that was what was creating her symptoms. Risk factors would be drugs or disease-related immunosuppression, collagen vascular disease, being an outdoor worker, being exposed to sources of the blasto, and interestingly, the studies show that having pets with blasto is not a risk factor. So if you have dogs and they've got either Giardia or blastocystis, that's not a risk factor. So this is a consensus on treatment, and in this study there was a combination either trimethoprim or nitazoxanide, which is a linea. Here was a really neat study that compared different treatments. And again, in a couple slides, I'm just going to show you a summary on treatment. So we'll see that in just a moment. Okay, the second thing here is we also have a traditional Chinese herbals, and these two, which I can't even pronounce, were effective in treatment of blastocystis. So these are obviously some pretty ugly parasites, and I want to just kind of give you a couple review things. First of all, we know that emulsified oregano oil can be really, really helpful in treating parasites, and this is the dose that was used in this particular study. Clinically, I will say, again, this is my personal opinion, this is not standard of care, but I usually use medications when I'm dealing with parasites because I find the herbal regimens are not quite as consistent. Dientamoeba is another amoeba that you may see on stool testing, and in this study they used several different drugs that were effective. You can see them listed there in the orange. This is my summary slide, and so just briefly, metronidazole, tinidazole plus or minus Bactrim tends to be most effective with the blastocystis, which is what you saw on my first slide on it. Dientamoeba, idaquinol or tinidazole. Cryptosporidia tends to respond to Alinea. Pinworm to albendazole or over-the-counter Pinex. Giardia can be tough to eradicate and probably one of the most harmful parasites out there. Typically metronidazole or tinidazole is indicated. And again, you can see here worms and other treatments. Okay, we're at our last case, so I'm going to fly through this and leave some time for questions. This 69-year-old male presented with acute delirium and diarrhea after a UTI. So he was in the hospital, and he was functioning phenomenally before that hospitalization, and once he was hospitalized, he was having trouble with memory. He didn't know where he was, and really severe presentation of delirium. Now, interestingly, he's a recovering alcoholic, both his son and his father, and in my clinic, his son was the one who brought him in. He was the caregiver. He was hospitalized for the 7 days and had a really difficult time with any sort of memory task, and interestingly, at the bottom here, daughter has the gene for celiac, and all of her children follow a gluten-free diet. His history personally was alcoholism, a history of a TIA in the 1990s, prostate cancer, restless leg, psoriasis, Parkinson's, and you can read the rest. He's been sober since 2002. So, he, at the age of 69, had a positive TT-GIGA. He had positive anti-gliadin, anti-deaminated gliadin antibodies. He had HLA typing done, which is a genetic test, and he was positive for the DQ2, and he was homozygous. So right there, those three things are predictive for celiac disease. We did not do an intestinal biopsy. It was interesting because I saw him just right after he was out of the hospital. The hospital had done these lab tests and didn't talk to him about it, didn't tell him the results. And when I got them, I said, bingo, there's a problem here. You need to go off gluten. It's obvious your immune system is reacting to this, and whether or not you've had the full-blown damage of celiac disease, there's definite markers here that show that things are not doing well, and this is an inflammatory process that is currently in process. Again, the gold standard would be an intestinal biopsy, but I did not see the need to put him through that, and we just took him off gluten. And that was after a discussion with him and the son as far as referral to gastroenterologist if they wanted the biopsy, and they decided against it. Vitamin D being low I put on here because I mentioned fat-soluble vitamin and malabsorption syndromes. And when you see that, you know there's probably something else going on. And again, a vitamin D of 19 is certainly extremely low. I listed here a typical workup of what I order. And if the patient has been eating gluten, you can also have them get an intestinal biopsy. My feelings on that, and again, this is a disclaimer, gold standard is an intestinal biopsy for diagnosis. But my personal preference on that or feeling is that if a patient is willing to go gluten-free, and there's what happens is you may or may not see the damage to the mucosal villi, but when you have someone who's DQ positive, they're having anti-gliadin antibodies, they're having neurological dysfunction, it's pretty important to get them on a treatment protocol. And so I usually take them off gluten if they're not willing to do a biopsy, no matter if it's positive or not. So there's multiple articles on gluten sensitivity in the brain. This is just one of many. And again, in this patient, definitely this set him over the edge. I think it was that in addition to that acute urinary tract infection. So ongoing inflammation and then an acute trigger. And there's definitely abnormal immunological response to ingested gluten in genetically susceptible individuals. And some of them may not manifest with any gut symptoms at all. It may manifest purely with neurological dysfunction. So for example, in this patient, had he had a gut biopsy, it could have very well been negative, and he's still manifesting with the gut-brain connection. So once again, a gluten-free diet is the prescription. These are other things that can manifest from silent celiac disease. So sometimes you can have presentations that are not related to the gut at all, and that patient may not have any gut symptoms. And if you see that manifestation and you see antibodies, you see the genetics, you need to get them off gluten. And there's a brand new disorder described by Dr. Alessio Fasano called non-celiac gluten sensitivity. This is exciting because it can really help a patient. The difficulty is we don't have good diagnosis. It's really a patient who resolves symptoms on a gluten-free diet. And again, we're starting to understand how important it is, because if we have a patient who eliminate gluten and they improve, this can be a really important factor. Okay, so future, I just want to briefly talk about the promise of poop. So exciting stuff here, because fecal microbiota transplant is cutting edge and being researched currently for C. diff colitis, Crohn's disease, ulcerative colitis, and I could see the future of this being very promising. Already the studies and the research and the people who have had transplants have had pretty profound effects, so stay tuned. The end of the book hasn't been written yet, but I think you'll see more and more information out of major medical centers on this fecal microbiota transplant and the success in certain cases. Okay, so I'm going to just remind you to connect with me if you'd like to hear more. And like I said, there's a LinkedIn group which I post frequent articles and research and things. You're welcome to join. You're welcome to email me, contact me. Love to interact with other clinicians. And I want to turn it over to Mike to tell you about all of their awesome products to treat gut infections.
All right, Dr. Jill, thank you so much. We covered a lot there. You did an excellent job, and quite a few questions came up.
I love the Pepsi X, love the probiotics. I use these all the time, and they really are fantastic products. So I just want to say I do use them in clinical practice.
Fantastic. And that article by Gerard Mullen that recently came out, I wanted to send that over to you. I think it came out just this past week.
Yes, I've seen it. I totally know. I think it was in the last edition of...
You covered so much great content. One thing that came up, and you mentioned you use both stool testing and organic acid testing. I was wondering, when would you use what, and what's a priority in your patient population?
Great question. I used to do stool testing first, and if I didn't get the answers I needed, I would add organic acids. Where I'm at right now, patients are motivated. They want answers. I often do both. I just feel like it's such good clinical information. And nowadays, with most of the programs, they're pretty well covered by insurance. And that's kind of if they're well covered, I'll order them both. If there's a problem with coverage, if it's more of a colonic issue, like an inflammatory bowel issue, I will often go with the stool profile first. If I have a very high suspicion of SIBO, I know, like I said, that a stool test won't really show me that, so then I'll probably go with the organic acids first.
Perfect. Now, quite a few folks are asking here about elevated levels of lactobacilli on these stool tests, and I know that's not necessarily always good, but what's your opinion?
Okay, so that's one of my little pearls as far as wondering if there might be SIBO. We know some types of SIBO, the hydrogen producing ones, can be related to elevated lactobacillus species. So this can be related to SIBO. Again, it's not a diagnostic test, but that would be one of those red flags. If they're having a lot of gas and bloating, they don't tolerate traditional probiotics, that would be one of those people that I would go ahead and order a breath test and a organic acid test to determine if they were suffering from SIBO.
Great. And that was another question too on the testing for the breath test. What lab do you use for SIBO?
I use the Genova breath test.
Okay, perfect. Now let's see here. Okay, there are a couple questions came in about Barrett's esophagitis and also eosinophilic esophagitis. Did you want to talk about that?
Sure. Barrett's, you have to be very cautious because they're going to be, from their gastroenterologist, on a PPI. It's indicated, and obviously Barrett's is associated with progression to cancer. So liability-wise, you don't want to take them off their PPI. What you can do is try to treat underlying causes, just like you would any patient. Look for H. pylori, look for imbalances, treat them, and as they resolve, you can, in coordination with their gastroenterologist, consider weaning off and that they stay stable. But again, that can be really tricky, so you want to be cautious because there's a lot of liability if they get gastric cancer and they're off a PPI. So that's something, be just extremely cautious and work with their gastroenterologist so you're not putting yourself at risk or the patient at risk. That's Barrett's. Eosinophilic esophagitis. Eosinophils we know can be associated with allergies and with parasites. Now typically esophagitis is not going to be associated with a parasite, but I'm looking for food sensitivities and allergies, and so I'll do a full panel of both IgE and IgG4 sensitivities for foods. I'll put them on a very strict elimination diet. I'll look for celiac, make sure gluten isn't a trigger. And sometimes these people get extremely restricted in what they can eat. I've had a couple cases where they needed to be on a short-term elemental diet, which is extremely, I consider it the most restrictive diet possible. But if you treat the underlying cause, take them off the foods that they're sensitive to, heal the gut mucosa with something like glutalamin, they do really well.
Fantastic. Now, you mentioned testing for hydrochloric acid. Are you using the Heidelberg test?
No,
Okay.
I'm
Okay.
not. Now, again, sometimes I would refer to gastroenterologist if the patient really wanted. That's something usually they do. But I will typically, I often do empiric. First of all, I will look at organic acids, and there's some markers like methylhistidine that indicates poor breakdown of protein, and if that's present in high levels, I wonder if there's a hyperchlorhydria. On the stool test, if there's elevation of putrefactive short-chain fatty acids, that can also indicate protein that's not broken down well, so another clue that there might be hypochlorhydria. Again, the symptoms I listed, and if all those are in place, I'll feel pretty comfortable doing an empiric trial with HCl or betaine HCl and seeing how they do and then dosing them up. And so that's often where I go.
Perfect. Now, we talked about the auto intoxication with that, NPR article and so forth. And so a person had asked about elevated levels of serum B12. We know that microbes do synthesize B12. So this is an elderly patient that's very frail, has multiple health issues and complications. Serum B12 is over 1,000 every time. So would that be linked to SIBO or auto intoxication possibly?
Interesting. So yes, or it could be, it kind of depends if that patient has not had any B12 at all, say in the last 12 months, well then you know it's not from any source. Often if you look at what they're taking, they'll have a multi with cyanocobalamin, or they'll have some source of B12 that they're taking. If they have been taking some sort of B12, that could be a conversion thing. Again, this gets really complicated, but there's some genetic mutations, MTR, MTRR, where patients can actually accumulate oxidized B12. So that could be a problem. Bacteria do synthesize B12, so that's the other source. It could be just internal,
Mm-hmm.
and that can be difficult to tell. So I don't have an easy answer.
Okay, you talked about physical diagnosis. Let's talk about the tongue. Someone had asked about what are some things that you would look for on the tongue to see if there's SIBO or other motility challenges?
Oh, great. And of course, any experts in acupuncture, traditional Chinese medicine, I love them because they're so good at tongue diagnosis in a much deeper level. But as far as I'm concerned, of course, a thin white coating on the tongue is often indicative of thrush or candida overgrowth. But you can have kind of a discolored, grayish, greenish, or whitish even colored tongue with a SIBO or a combination. I don't know if I specifically mentioned, but it's pretty important to note that very often with SIBO, because of decreased immune function, because of that bacterial overgrowth, over time they'll often have candida as well. So you want to be extremely cautious with just throwing in antibiotics if you haven't determined if there's also a candida issue, because you might flare that yeast. So the tongue can definitely indicate dysbiosis. Breath is huge. If they're having halitosis, that can either indicate fermentation from SIBO or candida overgrowth, or food allergies can cause that as well. So usually determining which one of those things is going on is important. You can see kind of fluffy sides of the tongue, like teeth marks on the tongue, sometimes with hypochlorhydria. Kind of a pale atrophic tongue can be B12 or anemia deficiencies. And those are the ones I can think of off the top of my head.
Perfect. Now, someone had asked about treatment-resistant blastocystis hominis, and I know you talked about you starting maybe with Flagyl, and then you mentioned I think nitazoxanide and different things. So, what would you suggest for a really tough case of B. hominis?
Yes, and this is so common, unfortunately. So the first thing I would do would be I actually usually if I'm doing drugs I go straight to tinidazole, because the effectiveness in the studies is there's a lot of resistance associated with Flagyl or metronidazole, and so because of that I often use tinidazole, and sometimes even as a first line. There's definitely more effectiveness of tinidazole. So after that, Alinea tends to be very effective. The downside is it's also very pricey. So that can be an issue for patients. And then if that isn't effective, artemisinin, which is an herb, can be effective. Artemisinin is a pro-oxidant, meaning if you use it long term or without breaks, you can actually cause more damage to the gut, so you have to be extremely cautious. So typically I'll pulse that, maybe 4 days on, 3 days off for a couple weeks or up to a couple months. You can also use combinations, and the study I showed you used a combination of either Flagyl or metronidazole with Bactrim. And I would say that right now, from my research, is the most effective regimen.
Perfect. All right, Dr. Jill. Well, thank you so much. This was very informative. We'll make sure we get the webinar archive video out to everyone. And Dr. Jill, thanks for your time and hope you have a wonderful evening.
Thanks so much.
All right, take care.